I was going to say, that's not quite Boston accent.
Yeah. Yeah, when he gets really into it, you get him pissed. It'll come out.
Yeah.
There you go.
I guess, I'll introduce myself. I guess I'm a PGY, 20-something, I guess. No, you guys, know me. I've been at UPMCs for about 12 years. Ivan and I have definitely run into each other quite a lot over the past several years, and it's really fun to be able to do these things. My major part of my practice is shoulder, so thanks for having us.
My name is Ariana. I'm another one of the sports fellows here. I grew up in LA and I went to NYU for a residency.
Welcome.
My name is Yanina. Dr. Musa's research fellow, but also working with Dr. Lin. Originally from Finland, did my med school in Sweden and came here after.
I'm Sahil. I'm a fourth-year medical student in University of North Carolina. I'm originally from Pittsburgh, and I'm here on a rotation with Dr. Lin.
Great.
I'm Nick Apsaloff, one of the orthopedic sports medicine fellows. Originally from Arlington, Virginia, right outside of Washington, D.C. Did med school and residency at Georgetown, and now here for fellowship.
Welcome.
I'm Abigail. I'm another one of the sports fellows. I'm originally from New Hampshire, and I did my training for residency in Rhode Island at Brown.
I'm Jaron. I'm one of the other sports medicine fellows, originally from Denver, Colorado. Did my residency training at University of Minnesota.
I'm Mike Fox. I'm one of the residents here my last year, and I'm from Washington, D.C. I'm going to be a fellow with Duke next year.
Congratulations.
I'm Fritz. Go to Pitt for medical school, currently a fourth year on a research year with Dr. Lin from Northern Virginia.
Good to meet you. Sorry, it's hard to see because it didn't turn the camera. Is anyone else over there?
No, that's it. That's
Perfect.
it.
Great. That's a big team. 6 sports fellows?
You got it.
How many attendings?
We have about 10 attendings, I would say. They have obviously 6 rotations where they're either with 1 or 2 for about an 8 to 9 week block. And, like any family, we sometimes mix their names,
That's fantastic. It's always great to see how different fellowships work. We can introduce our team. So we got a bunch of people here today. We got my co-mentors, my research team. I see medical students, partners of people. We have our collaborators and our visiting surgeon as well. So we'll go around the room to introduce everyone. I can start. So I'm Ivan Wong. Just like Albert, I try not to count the PGY years after training. Been here at Dal now for 11 years, I think it is. So most practice is shoulder and hip arthroscopy, and we'll talk about some of that stuff today.
Cool. I'm Ben Hoyt. I'm the traveling fellow from MS Somos from Chicago.
Hey guys, I'm Rob Adamson. I'm a professor in biomedical engineering at Dalhousie, working on some ultrasound imaging projects for arthroscopy with Dr. Wong.
Hello, my name is Eduardo de Avila. I'm from Mexico, and I'm doing currently a research stay with Professor Robert Adamson, also working with ultrasound imaging.
Hi, I'm Devin. I'm a research coordinator with Dr. Wong. I was the one that sent you guys all the emails about this journal club, so I'm excited to have you guys joining us tonight.
Hi there, I'm Jillian Carpathian. I'm one of the sports fellows. I did my residency training in Edmonton, and then I just came out here in July for the fellowship.
Hi everyone, I'm Makena Bogori from Nairobi, Kenya originally. I'm also one of the sports orthopedic fellows, and it's a pleasure to meet all of you. Thanks.
Hi, everyone. My name is Emily. I'm from Ottawa originally, but I actually went down to Vanderbilt to do medical school and then came back up to Saskatoon for residency, and now I'm here.
Hi, I'm Kathy Cody. I'm one of Dr. Wong's, co-directors in our fellowship. And I beat everybody in terms of what the PGY level is for sure here.
My name is Morgan. I'm a research assistant for Dr. Wong and registered dietitian.
Hi everyone, I'm Fernando Barbosa. I'm from Mexico. I trained there for residency and now I'm a fellow in upper extremity. Nice to meet you.
Hello everybody, my name is Lasha. I'm a research assistant working for Dr. Wong.
Does this work? Yeah. So we're looking forward tonight. I guess we got two papers we'll go through just for you guys to know. Hopefully you guys have the papers and had a chance to read them. We'll have one of our fellows kind of present each one. We'll kind of go through a debate moderated by our third fellow. And then hopefully we can all have some discussion around some cases. I think you guys may have some cases. Is that right? Yes?
Well,
perfect. So we can discuss all the cases. So again, two different centers. It'd be great to have a good exposure. This mainly is meant to be led by the fellows. We did this last year, and it seemed to go really well because with fellows, you have lots of different exposures, experiences, and then having a discussion, you guys would be able to have kind of a better exposure of what other people do because not everything is exactly the same at every site that you go to. So without further ado, let's start off with Emily. Emily is going to start talking about our first paper.
All right, so our first paper over here is on the arthroscopic Latarjet. This is just the title slide, so myself and also McKenna will be presenting these papers today. This was the paper. Hopefully all of you had a chance to read through it and understand kind of what they did and what the conclusions were. I'm going to take you through just a whirlwind summary of what the study was, just to refresh your memory. So in terms of the study design, this was a retrospective study of prospectively collected data. They included patients greater than 18 years old with symptomatic anterior shoulder instability who underwent arthroscopic Latarjet. These patients were included if they had off-track lesions or recurrence after a previous surgery such as a Bankart. Patients that were excluded included those who had inflammatory arthritis, glenohumeral or AC joint osteoarthritis, frozen shoulder or incomplete passive range of motion inflection and abduction, peripheral artery disease, and neurologic disorder. And all patients had to have had a minimum 3-year follow-up time. So in terms of their surgical technique, they actually had a separate paper that described their surgical technique, and so this is just some of the highlights of that paper. So first they performed a diagnostic scope through the posterior portal, and then opened up the rotator interval to visualize the lateral coracoid and then release the CA ligament, and then established additional portals like you can see in the diagram on the right, anterolateral, inferior, antero-inferior, and medial. Then a subscap split was performed. The coracoid graft was harvested arthroscopically and then prepared in situ using a double cannula. So this is all still within the body, it doesn't come out. Then the graft gets mobilized through the subscap split, positioned on the anterior glenoid, and then fixed in place with 2 cannulated screws over K-wires. So in terms of the postoperative protocol, patients were placed in an abduction brace for 3 weeks, and they were allowed pendulum exercises and elbow range of motion. And then afterwards, they started passive range of motion and active range of motion of the shoulder, progressive strengthening, and then they weren't allowed to return to sports until 3 months' time after a thorough clinical and x-ray examination. And for those who played contact sports, they actually weren't allowed back until 6 months. So in terms of the outcome measures, they looked at the perioperative and postoperative complications, recurrences, and reoperations. They looked at active external rotation with both the arm, with the elbow at the side and also with the elbow abducted. They looked at time to return to sport and also sports anxiety, pain during daily activities, and they used some assessment tools to look at the patient-reported outcomes. So they used the ROSE score, which looked at shoulder motion, function, and stability, the UCLA shoulder rating score, which assessed shoulder pain, function, active forward flexion, strength, and also patient satisfaction. And then the simple shoulder test, which looked at shoulder function and disability. And then they also looked at radiographic outcomes. So they took x-rays post-op and also 1 month after surgery in order to assess the graft position. And then they did CT scans at least 6 months after surgery. And this was to look at graft positioning and healing and also the angle between the screw and the glenoid. And then these were the baseline characteristics. So I'm not going to go through all of it, but just some of the highlights here. So there were 93 patients, and some of the patients had bilateral surgery, and so there were 95 cases total. Most of the patients were male. The age at the time of operation was about 28 years old. And then patients had had a mean of 12.7 dislocations before the surgery. 18.9% had had previous shoulder surgery, and all the rest were primary cases. And then follow-up time was about 69 months or 5.8 years. So in terms of the results, the mean surgical time was 93.6 minutes. There were 5.4% complications, with 4 of these requiring reoperations. And so the reoperations were for either for pain, which required screw removal, or actually for graft rupture. 2 of the patients had redislocation after a high energy trauma, which was classified as a road traffic injury. And they didn't report on any nerve or vascular injuries. And then in terms of range of motion, comparing the unaffected versus the affected shoulder, there actually was a significant difference in external rotation, both with the arm at the side as well as the arm abducted. And so there was a statistically significant difference, but if you look at it really, it's like 3 or 4 degrees, and clinically, I think you could argue that it would be hard to really find a difference there. Return to work, so almost all of them returned to the same employment status as pre-op. And then for return to sports, so there had been about 91% who had been engaged in sports preoperatively, and all of the patients who practiced sports pre-op were able to return after surgery. 10.6% had changed sports, and then 15.3% had some sports anxiety. 12.9% experienced pain during daily activities, and most of these patients were heavy manual laborers. And then in terms of the patient-reported outcome measures, the ROSE score, UCLA score, and SST scores were all significantly improved from preoperatively. Then when they asked patients if they were satisfied with the surgery, 83% reported that they were completely satisfied, and only 2.1 unsatisfied. And then for the radiographic outcomes, so there were about 64.2% of cases who actually had the CT scans. There were some patients who refused to do this. They found that about 4.9% each of the bone block being too high or too low as compared to a clock face. And then there were 3.3% which were located too medial, which was defined as greater than 5 millimeters. The average screw angle was 28 degrees, and they had 6.6% stable non-unions. And when they defined stable, they just meant that the screw was not loose. And then there was some graft lysis as well, so 14.8% had superior graft lysis, which was defined as lysis around the superior screw, and 1.6% with inferior graft lysis, or lysis around the inferior screw. And then lastly, they did also look at predictors of clinical outcomes, and they found that younger age at operation time and also younger age at first dislocation were predictive of higher outcome scores. And lower pre-op UCLA scores predicted pain during daily activities, and then also that complications were directly associated with age at operation, time from first dislocation at operation, and pain during daily activities. Some of the limitations that they cited was that this was a retrospective study, and they didn't have a specific pre-op bone loss measurement, so they kind of just included patients with off-track lesions or those who had failed previous surgery, but they didn't really have a criteria or a cutoff for bone loss. They also stated that they didn't include professional athletes, so even though many of these patients were very active, they did state that these results may not be applicable to the professional athletic population. And then, like I mentioned before, the CT scan was only obtained in about 64% of patients because some of them did refuse the additional radiation. And then, as this procedure is quite technically demanding, people should be cautious that less experienced surgeons may not achieve the same results. So in conclusion, arthroscopic Latarjet is associated with excellent clinical outcomes and radiologic outcomes at 6-year follow-up. Patients are quite satisfied, and there is a high rate of return to work and return to sport. And then secondarily, lower age at operation and shorter time between first dislocation and surgery were associated with better outcomes. So that's the end of this paper. I'll now turn the time over to McKenna, who will talk about the AAGR paper.
Okay. Good evening again. So I'm presenting on the paper on arthroscopic anatomic glenoid reconstruction using distal tibial allograft for recurrent anterior shoulder instability. This is a paper that was published in the American Journal of Sports Medicine in November of 2020 and hails from here in Halifax under the team of Dr. Ivan Wong. As we know, glenoid bone loss is a contributing factor to recurrence of shoulder instability, and particularly so after isolated soft tissue stabilization procedures, with some studies quoting it as high as 89%. Various glenoid reconstruction procedures have been described, including the Latarjet that Emily has just talked about, either open or arthroscopic, iliac crest using the distal clavicle or free bone block procedures. So the Latarjet has been the gold standard, but there is an unappreciated complication rate of up to 15 to 30%, including neurovascular injuries, dysfunction of the subscapularis muscle, difficulties in revisions, and the non-anatomic nature of the procedure leading to glenohumeral osteoarthritis. So this technique of arthroscopic anatomic glenoid reconstruction was developed, and it spares the subscapularis split, allowing for an additional soft tissue, either capsulolabral plus or minus remplissage, restoring both the soft tissue and bony components. So being a new technique, it was lacking in clinical and radiological outcome data. So the purpose of this study was actually a fast description of the outcomes from this new technique with a minimum of 2-year follow-up. And they did have, the hypothesis was that the recurrence rate would be low with good to excellent outcomes. As well was a retrospective study of actually all the consecutive series of patients that underwent this technique. 73 patients were included between 2012 and 2017. The inclusion included a glenoid bone loss of 15% on preoperative CT scans, which of course then covers your subcritical bone loss percentages. Minimum of 2-year follow-up, pre- and post-operative functional outcome scores collected, and there was no patient excluded. The surgical technique as well is a technique described by Arthroscopic and Wong, where general anesthesia and lateral decubitus position, diagnostic scope through the posterior portal as in a standardized fashion. From an anterior portal, they debrided the rotator interval, exposing the conjoint tendon and coracoacromial ligament. Creation of the Halifax portal, also described by the team by an inside-out technique where a switching stick passed through the posterior portal parallel to the glenoid, superior to the subscapularis and lateral conjoint tendon was used and made push out through the skin through the ductopectoral interval. Measurement of the glenoid bone loss was also done and used to determine the size of graft required on the back table. The graft that was used is the posterolateral corner of the distal tibia allograft, frozen, which is available from the bone bank here in Halifax. Graft insertion via the Halifax portal and then fixed with 3.5 cannulated screws. And then finally, an inferior to superior shift of the capsulolabral structures with all suture anchors. Postoperatively, shoulder brace in neutral for 6 weeks. However, start passive mobilization to neutral for the first 2 weeks, and then progressively increasing over a period of 6 to 8 weeks with the aim of retrieving full range of motion. After the 8-week mark, and once full active range of motion has been achieved, muscle strengthening and scapular control was allowed, and return to sports was also allowed from 6 months. The outcome measures that were used in the study are the clinical Western Ontario Shoulder Instability Index and Disabilities of Arm and Shoulder Hand Questionnaire. These are both validated outcome measures. They are quite comprehensive and use the Likert scale, which fabricates for better data distribution. Radiographically, postoperative X-rays and AP lateral and axillary views were evaluated. And as well, CT scans were compared preoperatively and around the 1 year mark, 1 year postoperative, that were assessed by independent blinded observers. And the measurements that were being collected from CT scans include bone healing, either defined as either union or non-union, as bone resorption or graft resorption, which was defined either less than 25, less than 50, or more than 50%, depending on how much this amount of screw length that was out of the graft on CT scan at 1 year. Graft positioning as well was determined both in axial and sagittal cuts in the medial lateral plane and superior inferior plane. And the alpha angle, which is defined as the angle between the screw shaft axis and the native glenoid, and ideally should be between 15 to 25 degrees to prevent nerve injury. So just going through a few of the important points from the results is that there was 73 patients included in this study as mentioned, and these were the actually consecutive first patients who underwent this new technique. The average preoperative bone loss was actually between 25.3% with a standard deviation of 10.6. With 66, which is 90.4%, had postoperative CT scans, with 7 being lost to follow-up. The clinical outcomes as well, the WOSI and the DASH scores, did both show significant improvement in the pre versus post-operative scores. And each of these, for both the scores, the delta change was more than the minimal clinically important differences for each of the scoring system, quoted as 92% specifically for, so 92% of patients achieved the MCID for WOSI. There were no frank dislocations post-operatively after during the end of the data collection period. I think I should have mentioned also that the average follow-up period was 4.7 years. So as much as there was a minimum of 2-year follow-up, majority of the patients had been was mean of 4.7, which I would say approaches medium-term results. So no frank dislocations post-operatively, no apprehension on clinical exam other than one patient who had a subluxation, defined as a patient perceived subjective instability with dull aching pain and slight weakness in the subscapularis. There were 5 hardware complications noted that required surgical removal of the screws, and these all resolved with removal of the screws. They reported no nerve injuries within this data collection period, no infections, graft failures, or graft or glenoid fractures. The union rate from CT scans, and remember, all assessed by independent observers, was 100%. In terms of positioning, 92.4% was flush in the medial lateral plane and 97% excellent in the vertical plane. The mean alpha angle was 18.3% with a standard deviation of 5.7, which falls between the normal range. In terms of graft as resorption, which always happens to be the question that comes up when you're using allograft in any type of procedure, there was up to 30% grade 1, 28% had grade 2, and as mentioned, so grade 1 was less than 25%, grade 2 between 25 and 50% of the screw shaft exposed out of the graft, and grade 3 would be more than 50% of the screw shaft. Although 9 of the 66 patients, which is 13.6% of the study participants, had more than 50% graft resorption, it was interesting to note that the sagittal diameter of the graft remaining and the anterior posterior diameter of the reconstructed glenoid still fell within the normal range of the size of glenoid, approximated normal size of the glenoid. And interestingly as well, as table 4 shows, is that patients with or without hardware complications did not have any significant difference in their AP diameter of the reconstructed glenoid or the graft. So I think the results of this study show that AAGR with distal tibial allograft in lateral decubitus position has excellent clinical outcomes with 100% bone healing and restoration of the normal size of a reconstructed glenoid, even with evidence of graft resorption. It's quite comparable. The results are quite comparable to most of the other studies, including the one that Emily has just mentioned with low complication rates. I would say, well, the advantage that AAGR has probably over Latarjet is being anatomic by preserving the subscapularis muscle coracoid process, conjoint tendon, and creating an articular surface for the glenoid. Graft resorption is a reality for all types of grafts, even autografts. But however, it was noted in this particular study that the resorption does not progress between the 1 year and 2 year time point, and matching of the size of the graft with the amount of glenoid bone loss minimizes screw exposure. And the graft resorption is seen to be attributed to physiological bone resorption, like according to Wolff's law, where the glenoid after big bone block augmentation would resorb more because the graft is too big, but still to the size that is physiologically acceptable for the size of a normal glenoid. And as well, the sling effect is probably not as important in bony block procedures as Latarjet usually provides that. In terms of limitations, it was a retrospective study, and it was mentioned that the response rate for the DASH questionnaires was a bit limited, and that's why MCID was mostly reported only for the WOSI score. And as well, no control group, but being the first consecutive patients for this new technique, I think the results were still plausible. Thank you.
Thank you, McKenna and Emily. That was very good overview. So I'll be moderating the debate between the two of you. And so essentially, my thought was just to get you guys to have a broad discussion about Latarjet versus AAGR. And I will say Emily's at a little bit of a disadvantage because here we do a lot of AAGRs and I haven't seen a Latarjet yet. So my first question for you guys is what benefits do you guys see from each procedure and why would you recommend it?
Sorry, we're just trying to share another presentation here. All right, guys, so we're gonna get started with this debate. So in contrast to this debate, McKenna and I are gonna be very friendly and we're not gonna be calling each other names. But this Saturday Night Live skit did provide a lot of entertainment during the election time. So, Jill, you had mentioned, you had talked about asking about the benefits of each of these. So I thought I would just put this table up here, and it just kind of shows some of the technical differences between the two procedures. And so for the arthroscopic Latarjet, benefits would be that, I mean, Latarjet has always kind of been considered the gold standard for instability with bone loss. We are seeing new techniques now, but that's kind of, oh, thanks. That's kind of the standard that we use to compare to other things. In terms of the graft preparation, you never really have to take it outside of the body, so it's prepared in situ. It may not seem like a big deal, but when you're preparing something on a back table, there's always a risk that as you bring it over to the operating table, you could drop it and then have complications with that. And then also the rehabilitation time, we did find that in the Latarjet study, the return to sport was a little bit earlier at 3 months versus 6 months. So yeah.
So for AAGR coming in as a newer, kind of kid on the block, I feel like the advantage that it would have, number one, is revision cases, right? So if you need to revise a Latarjet, you have no other coracoid autograft. So this comes in handy at that point. Also, depending on the size of your bone loss, the coracoid is a limited size that you can use. There's no more than what is there. But with a distal tibia allograft, you can actually design the size of graft that you want to recreate. And that actually becomes the better, or when you actually make your graft the same size as the defect, the healing and resorption is seen to be less. Also, sparing of the subscapularis, right? It's an important muscle around the shoulder and facilitates a lot of range of motion that sometimes maybe not as, the injury rates maybe are not as high as we expect them to be, but for the ones who have it, it's significant. Yeah.
I do want to just add as well, though, that when you are using the coracoid autograft, you can use your own tissue. So you have a little bit of that. I mean, there's always a theoretical risk with allograft of disease transmission, theoretical risk. I don't know that we ever see it, but it's definitely something to be aware of. And then, of course, as McKenna alluded to with the allograft, you do have the issue of graft resorption as well.
Even autografts have graft resorption, but
not as high. And then the other thing, of course, as well, to be aware of at least, is that not every center has distal tibial autograft. I mean, everyone has a coracoid, we hope. But I have heard it said that our bone bank here is one of the best, maybe even in the world. Like we have a lot of resources. We have a lot of allograft here, but not every center has this, and so.
Can I make a comment or a question for anyone and maybe for your great team that's there? So there's much, and this was brought up on a slide here, and there's much brought up with the Latarjets for the sling effect, and you guys have very compelling data there, and this is excellent research. It's well known. It's presented a lot. Why do you think, is that an overblown biomechanical issue that people talk about? Are we seeing sort of the same type of outcomes without the sling effect because the subscapularis is preserved and it's not split or breached? And does it have to do with the technique that you guys described, which is to say you put the bone graft extra articular and then you fix the Bankart and labrum on top of it, or the Bankart and the capsule on top of it to make it an extra articular? I always kind of wonder, why, if the outcomes are essentially similar, sort of what is the deal with this sling effect?
Yeah, so I think first of all, from the from what I learned, the evolution of this technique has kind of changed over time. All of these patients happen to be included in the paper, where at the beginning, the graft was sort of intra-articular and then now moved extra-articular. And then, as you mentioned, the inferior to superior capsular shift that is part of and parcel of this technique is also part of the stabilizing force or biomechanical aspect that could be contributing to the success of it.
Your comment was good.
Oh, yeah, I was just sort of the overall sort of thing that we were sort of discussing this morning as far as the evolution of all of these as well as sort of the studies that showed that ilia, crest bone graft, and Latarjet, as well as sort of the distal tibia graft versus the Latarjet, all have similar outcomes. With the sort of theoretical idea just being that you weren't born with a sling. It's an extra anatomic modification that you do in order to prevent this instability when you have bone loss, but you don't really need it from a physiologic perspective. You're adding that on top of what you already are adding to a person, so probably it's not necessary if you recreate a good stable shoulder.
So again, I think that is an argument that I'd use, right? So Ben or Dr. Hoyt came here. It's really interesting to see what his thoughts are just watching this for a couple weeks. I'll tell you, in North America, what is our gold standard for shoulder instability? Right? It's an arthroscopic Bankart repair. We have excellent results. That's everything that we compare to in North America because we have great data on this. And the only failure that we're having is when they have repeated dislocation getting bone loss, right? So repeated dislocation with bone loss, arthroscopic Bankart repair is failing, and that's why we're having trouble with this. So if we can recreate the bone and we repair the Bankart, then we should get the same as what we're getting with an arthroscopic Bankart repair. So I know everyone argues the sling, that's what you talk about, but now there's numerous papers out there showing that you don't need a sling if you can recreate the bone.
Yeah. I would say the other thing that your fellows nicely mentioned here, which I think gets a little bit granular with all of this, though. You know, the Europeans, they go straight to Bankart, or they go straight to a Latarjet when there's no bone loss, and you know these surgeries are notorious for having especially superior screw lysis, and I think it's due to Wolff's law. You don't need a huge chunk of glenoid or a huge chunk of bone in addition to what you have with the glenoid when that's not the actual problem, right? You have an instability problem with no bone loss and you put a bone graft there, it's probably going to resorb because it doesn't see any stress. And I think the nice thing about your technique, Ivan, is that you can really match the amount of bone loss. Like you can shape the graft to match exactly how much is missing. And I think in your paper, when you saw sort of the grafts that had more resorption, not resorption, but they had more resorption around the screw, they were probably because the bone was bigger, right? The bone graft place was much bigger than what the physiologic or native glenoid was. So like things tend to reshape into the native glenoid.
Yeah, you're actually right. Most people miss that part of the paper. They read the paper, say there's 50-some% bone resorption, 50% or something like that. They say this is terrible. But if you look carefully, exactly what you said, the size of the glenoid at the end is the same no matter what resorption happened. Because we took all comers from the very first case we ever did before we understood how bone remodels. And at that time, when these were usually the big failures, failed everything else, coming with large Hill sacks, we didn't know what to do with Hill sacks. We knew that if you made the glenoid tract big, the Hill sacks doesn't engage. So we tried to make the glenoid tract so big it is physically impossible to engage. And it was true. There was no dislocations. But then if you get a CT scan 2, 3, 4 years later, you see it go back down to normal, and then the screws are irritating them. That's how we learned not to make them supersized glenoids. We are only aiming to make normal sized glenoids. And really for the past 5 or 6 years, we have never seen a single one that we needed to remove screws.
Yeah.
Does all your fellows know AAGR or arthroscopic Latarjet?
That's a great question, right? I just don't like, none of us do arthroscopic Latarjets. I see it presented all the time. It just, I don't know. I mean, it can be done, and I'm sure if you have the time to train and go through the learning curve, you can do it. But every time I see it presented at a meeting, there's never like a clear like video. It's like 1,000 portals. You can add all the portals up, and they would probably, the incisions, and it would equal a big incision, you know. And I just don't think that I don't think it'll ever catch on as a regular surgery, just because it looks so impossibly difficult to do. I have actually never. I mean, I know you used to do some arthroscopic Latarjets, and obviously, you know, it can be done. It can be done well, but it just looks complicated. So I don't think these guys, unless you guys have you seen arthroscopic Latarjets? Yeah, I mean, it's one of these things where you see it presented with the Europeans and some of the Asians over in the conferences, but I don't think you ever see it regularly here. Last year I did do a lab with the guys here with your AAGR technique. We had your video up and everything. I've actually been trying to coordinate a time where we could do it with you, like you know, you've shown sort of your virtual reality where you can kind of see what we're doing and right on the screen. I think that would be invaluable for us. And I quite honestly, I think this whole space of free bone block, I think is really sort of the next generation of instability, because the current stuff we have right now, whether it's soft tissue, Bankart with or without remplissage or Latarjet, I just don't think it's like we're there with like an excellent procedure. And I think if you have a procedure that, you know, that is particularly good for subcritical bone loss or sort of critical bone loss, that can be widely adopted, and everyone here understands arthroscopic techniques, are very good with arthroscopy. I really think that you guys are, you know, that you're leading the space in this field.
No, that's great. I think Jill actually has some talk that she was debating whether or not to talk about the technique. If you guys don't have it, this might be great for your fellows to go through. It's also great for me to watch to see how she teaches it. So let's let her keep going with the questions, and then we'll go on to the cases. And I think doing a combined lab, actually that would be a lot of fun to do with your team. We could do it with ours as well.
Yeah, that would be great. Because quite frankly, Ivan, I kind of want to learn it too.
Okay, well, we already touched on a lot of the questions that I was already going to ask. So I guess some of the more things we can just round out in the conversation is maybe you guys can go and say what you think the biggest challenges are in each procedure that you have to kind of overcome.
Absolutely. So I'll start. So for the arthroscopic Latarjet, one of the biggest challenges I think would be the technical aspect. Very difficult to learn, need an experienced surgeon, and that was even acknowledged in the paper, that this one surgeon was very experienced, very high volume, and other less experienced surgeons may not have the success that he did. The other thing is the graft, even though it's completely prepared in situ, I think it would be difficult, at least conceptually for me, to prepare it all arthroscopically. I think it's easier to see it on the back table with your own eyes. You can get the measurements really precise. And I do wonder if that might be why the screw angle was a little bit higher for the Latarjet. I wonder if that might have been why. So I think those kind of are the biggest things, is just the technical challenges of doing this procedure.
So
You guys here have done open Latarjets this year, right? Yeah.
I haven't done one yet.
Some of you guys have. So, you know, the what is a fuzziness of the coracoid graft that you've experienced?
I mean, just where is that? Safely take it. Safely like take an exploding. Take it, but
I mean, besides like, you know, there's technical challenges trying to get like the graft the exact size you want, but I think because it's still attached to the conjoined tendon, it's actually kind of a pain in the ass sometimes to kind of manipulate it where you want. So it's true for an open procedure. I think it's going to be true for an arthroscopic procedure too. You know, the conjoint has a pretty robust attachment onto it. And it's, you know, I guess you can have a cannulated system where you can hold it, but even when you have that, I think it's still very hard to kind of manipulate it, yeah, between the subscap and get it exactly where you want, because there's all this tissue that remains pulling on the graft. So yeah, I think I would agree with all those nice points there.
So I think you want to bring one thing up very clearly, because Albert's already said most of the world doesn't do arthroscopic Latarjet. And perhaps the choice of the papers wasn't right because it was chosen for arthroscopic versus an arthroscopic. The real question in North America comes to a surgeon like Dr. Lin, Dr. Hoyt. What will it take in terms of a new procedure for you to consider something other than an open Latarjet for somebody with significant bone loss, failed Bankart with bone loss, something along those lines? What is limiting with your open Latarjet that would get you to choose to find another procedure?
Yeah, for Ivan, from my standpoint, I think the open Latarjet is an imperfect procedure for many reasons. It's also technically challenging to do. It's well known, you know, the complication rates from it are well known. And we've all had patients who've had, you know, neuropraxic injuries, and these are all sort of young patients. It's usually very, you know, I've had two in my sort of 12-year career where I've had musculocutaneous nerve palsies. Both have resolved, but you know, imagine talking to a 15-year-old who can't like lift their elbow for 3 months. It's terrible. And so I think it's a good procedure, but I think it's demanding. And I think, to be honest, a perfect procedure is one in which you can use all the arthroscopic techniques that you know how to do and be able to recreate the bone loss in a reproducible sort of arthroscopic way. And to me, I think that is sort of, you know, I think that is why there's so much interest in these free bone block procedures arthroscopically, because I think most of us feel very comfortable arthroscopically managing this, but it's not the arthroscopic Latarjet, because, you know, that procedure looks like it's got too many steps to me.
Not specifically to add, other than the fact that we sort of addressed this when we were having our talk this morning, essentially that, you know, the complications, while not outrageously high for the Latarjet procedure, are sort of untenable, that you don't really want to have to deal with the fact that you are throwing away an important piece of bone that's attached to your tendon that also has sort of essentially just 5 centimeters distal, your musculocutaneous nerve, and you don't really want to get wrapped up in all of that nonsense when you try to figure out your revision plan. But DTA, essentially, you can take out the graft and try again. So I'm probably going to do DTAs. Yeah.
Maybe just to mention, like for all of us fellows, the learning curve issue is something that we always need to consider. I mean, you're in fellowship 1 year. 1 year somehow seems like a long period and then becomes a very short period. So a technique that has published, there's published reports that the AAGR versus arthroscopic Latarjet, it's easier to learn the AAGR. So, I mean, that's probably one, you know, a thing that would make us more encouraged to use it. However, though, still availability of allograft as well is a rate limiting step. I come from a country where we don't have that. So open Latarjet is what is done. And if that's what you have, that's what you have, I think.
Perfect. Thank you, McKenna. I was actually going to ask about the allograft availability in Kenya. So I think that's all my questions, unless anybody else has any. So I was going to present my case, and then we can go through the steps for the AAGR. So I'll just load up my case here.
I love that. Ivan, while she is loading that up, I want to ask a question for you that I'm sure comes up periodically when we're at these meetings. So we're talking about sort of feasibility of arthroscopic surgeries, and to some degree, endo buttons have a very there's a very seductive thing about endo buttons, because you can just drill the holes and just kind of shuttle the graft using, whatever shuttling suture you want to use. And I know you've definitely have presented on that, and you guys, I know you tried that for some period of time. You had sort of an unacceptable failure rate, and other people may have not demonstrated that. And so what is the difference between what, potentially sort of what you've presented, what those other techniques are presenting? There is, I think it's probably technically easier to use an endo button, just kind of shuttling it. But I don't know, I sort of wanted to get your thoughts about that.
Absolutely. So you're right. Those other suspension techniques, just call it suspension because it can be button, suture anchor, non-screw fixation, are very attractive because it's all the techniques that we know how to do, right? You don't have to have a straight line shot. You don't have to have a Halifax portal. You use the same portals that you do. And I actually changed my technique over, I think it was 2019. I can't remember when I switched it. Literally, Smith & Nephew came open with it. It allowed us to use it. We did it for a whole year, and almost 2 years. And then I was really happy with it. We taught with it. It's so easy to teach. That's actually how I started this virtual teaching, because it was that easy. And then they started coming in failing. So 2 years, literally 2 years, we're getting ready to write our first 2-year paper. They're coming in for their evaluation, and my first one dislocated, and we ordered a CT scan. I was like, okay, it's just one. We did 30, 40 of these. And then the next month, 3 came in, and the next month, 2 more came in. And then I was like, I'm not doing any more until we get a really good data set of this, and I refused to teach it. And then I went looking deeper, and this is the scary part. So, the papers that are out there already talking about button fixation to screw fixation, saying that they're the same. But if you read the paper carefully, it's not the same. They say that they are sufficiently strong. The buttons are sufficiently strong to withstand the forces for rehab. There's no question that screw shear force is way stronger. And Arthrex was actually one of the ones that funded Arciero, Mazaka and their group out of Connecticut. And they buried that study because it looked so different, right? Then Proventure came on and then wrote it a different way. So that paper is with Corey Edgar, and they're actually going to publish it now, because I just encourage them, like, look, they're no longer funding your place. You should just come up. The paper's all done. People have to know what you guys have for results, because this is dangerous. And it irks me that I went down a path with information that was not full, and I taught people how to do this. And I still regret doing those, but it's a learning lesson. Those that do work, because I'll tell you, in our group we had 60% actually that did really well, but 40% didn't. And I don't have a good reason. We actually have 2 papers coming out. One was to show the failure rate, and that one should be, actually we're submitting it right now. We've presented it once. The following year we presented Anna for the surgical review. So we went through minute by minute the entire case, how we did every surgical video to try to find out if there's a reason between those that failed and those that didn't. And we cannot find a technical reason of whether it was tension, position, angle, all that kind of stuff. So the comparison group is actually a perfectly designed study. There was no difference in any of these things other than the fixation type. The graft, the procedure, the time, the skill, all the same with all these patients. So I have no question with allograft distal tibia, do not use suspensory fixation.
Okay, so hopefully my screen is showing properly. Yeah, so we'll go through a case and then I'll kind of go through step by step the AHER with some videos. So the case is Miss FL. She's a 24-year-old female. She's right-hand dominant. Her first dislocation was about 5 years ago from a rugby injury. She had a Bankart repair 2 years ago. She was doing good for 1 year, then dislocated with lifting overhead. She now dislocates many times per year and is quite disabled from it. So on physical exam, she has full passive and active range of motion. Her strength is normal. She has a positive apprehension, relocation, and rebound test. And she has a normal neurovascular exam. So these are her initial x-rays after the initial redislocation, just documenting that it's an anterior dislocation. And you're kind of wondering whether or not there might be a humeral bone defect there. These are following post-reduction, and again, you can see the Hill-Sachs lesion there. And then on the AP X-ray, you're wondering whether or not there may be some glenoid bone loss or glenoid fracture. These are our CTs. The top middle image, you can see evidence from the previous Bankart repair and the anchors. And you can see the bone loss there. But you can really see it a lot better on these 3D CT reconstructions. So you can see a pretty big Hill-Sachs lesion that's quite deep. And then you can see there's a small amount of bone loss or fracture, but likely some long-term erosive bone loss. As with the perfect circle technique, she had about 12% glenoid bone loss. Sorry, this backup feed is really messing with my speaking. So I thought we could pause here and then we can talk about options for what we would do for this patient in a contact athlete that had a failed Bankart repair.
Pick on one of you guys. So, Jaron, what would you do for
I think when I see a young contact athlete with subcritical bone loss, meaning less than 12% or less than 15%, in my experience, this could be treated with an open Bankart and capsular shift. I think that's a pretty good procedure, for that level of bone loss. But certainly, I think an arthroscopic, revision Bankart procedure wouldn't be acceptable. Either be an open Bankart or something where you're adding more bone back to the defect. So Latarjet or just the tibia, but probably open Bankart.
I love it. The open Bankart. What do you guys think over there at Halifax?
Never seen one, but I feel like it's been brought up at multiple conferences. So I'd be interested in seeing one, and I think it does have benefits in of itself for the specific patient.
Abby, there's that amount of that, we don't know sort of the Hill-Sachs interval here and that stuff, but what do you think about that Hill-Sachs here? Does that concern you with Jaron's open Bankart?
Yeah, and I think I don't think Jaron's open Bankart is the concerning part of it, but the Hill-Sachs, yeah, we could look at the distance to dislocation, but it's very, very sizable just based on looking at it. So adding, like a remplissage or even a bone procedure for the graft or something for that, but I think adding remplissage for saying a contact athlete makes sense to me.
So remplissage with like a soft tissue procedure or a remplissage with a bony reconstructive procedure?
I think I guess I'm gonna stick with the soft tissue.
You're going to go with an open Bankart
yeah,
with a remplissage.
Bankart with the remplissage.
All right, all right. No, I love it.
On that.
Okay.
Is there a lot of experience with open Bankarts in Pittsburgh?
Have you guys seen some open Bankarts this year? Yeah. I mean, we do them for right instances. I think they do get, particularly in some revision scenarios like this in contact athletes. I mean, I don't think that's a wrong answer here. If you look at some of the some of the data from Yonders, and actually Open Bankart may have some of the longest term follow outcome studies, some of them 20 years. And many of them have single digit recurrence rates. And so I think in the right hands, Open Bankart can still be a very good procedure. Some of these studies are older, so you don't know sort of what the track concept was with them. Are they on track, off track? How big was the hillside collision? Are these near tracks? But if you look at some certain studies, like in primary scenarios, like Pagnani has a paper that is off-quoted in contact athletes with bone loss on both sides. Revision rates are actually quite, or recurrence rates are actually quite low with an Open Bankart, perhaps in a scenario like this. So I don't think that's a wrong answer by any means. I think if you poll a lot of shoulder surgeons, I'm sure you're going to get a lot of different answers here. I'm sure with, Ivan, this would be an AAGR type procedure, which I think is probably a great procedure for this too, because you can restore the bone loss, probably restore the track with that as well. And you would get a ton of people who would say, do a Latarjet on this. My concern with the Latarjet, honestly, with something like this, though, is you have 12% bone loss, and like we were talking about with having a bigger bone block, is that you're going to get resorption. I think. I don't think this is enough bone loss at a coracoid graft here. I think it's going to be actually quite large in comparison to the native glenoid, and so I'm not saying that would be the wrong procedure, but I think it's imperfect.
So I agree. There's lots of imperfection in every surgery, right? So surgery is not normal by any means. We're changing something. There's always a give and take. Why I asked with Open Bankart, because I don't have experience with it. Dr. Cody here has experience with it, so I need to ask Dr. Cody what her experience is with Open Bankarts. My only trouble with this is, as we have less experience with techniques, we are not the experts at it anymore. And when you get something that you're going to violate the subscap, the thing is, I worry about the subscap. Anytime we violate the subscap, I worry about. If we do a subscap split, of course, it's less worrisome, but there's a lot of people do takedowns, osteotomies going through there. So things really get screwed up when we lose subscap, because we only got one muscle in the anterior aspect, and that's probably the only muscle we don't have good transfer for either. So that's the part that I worry about mostly. But what's the experience with Open Bankart?
Yeah, I mean, we're talking 20 years ago, so I'm kind of laughing because it's like what's old is new again. I think the patients had good outcomes. The only thing I'd say that I would find a bit different was I found more patients had difficulty with external rotation. So I think your procedure, they get better range of motion. I would say the Open Bankarts, in my experience, the way I used to do them, you would definitely lose external rotation.
Sorry, so this brings up the follow-up question. If we're going back into all this, and there's no question, I agree with you, Albert, that the data in long-term Open Bankart has been good. The data with open long-term Latarjet is also good, right? So those are really the gold standard. Test of time is always going to be the most important thing, and nothing else matters. What we do know, though, is Bankart long-term is not as good. Arthroscopic Bankart, sorry. So what makes an Open Bankart that much different? What is it? Is it the scarring? Is it the damage to the subscap? Or is it that inferior to superior shift? Is it that we because Open Bankart, there's not one technique, right? There is subscap takedown, there's subscap split, there's a imbrication of the capsule, there's a teeing of the capsule based on the glenoid side, there's a teeing of the capsule based on the humeral side. What are we talking about for an Open Bankart? And that's my problem, is I don't know what the right technique is, because for me as an arthroscopic surgeon, I'm trying to imitate the open technique. And I think that the arthroscopic Bankart has evolved, right? It started off with arthroscopic staples, then arthroscopic tacks, then arthroscopic sutures without the anchors. Now the anchors are improving, and in fact, we're trying to do this inferior to superior shift that's very similar to an Open Bankart. So we really need to figure out what about that Open Bankart has made it successful that we can isolate.
Personally, I mean, I think no matter what technique you use for it, whether you take the subscap off and you tee it, or do a humeral base, glenoid base, or you just split the subscap and then you try to imbricate it, I think that you get a much more robust imbrication. That's I think, your ability to plicate, like a double plicate the capsule, I think is much more achievable than arthroscopically. We take a bite, but what we're really doing is we're actually just kind of curling up one edge and kind of bringing that edge closer. Whereas in an open Bankart, you're actually taking the two layers and actually shifting them together, which I think is a very different thing than crimping it. We crimp it when you're doing arthroscopically. And so that's probably why you get external rotation loss, because you get like non-physiologic sort of, double layering. And I think that's probably why it's a little bit more robust. That's sort of my thought. We try to achieve arthroscopically, but I think we're doing a different thing.
So I love your description of this thicker tendon, because this is what we're trying to do during surgery. I know we've been working with Ben because we have several live surgeries just the last week. I don't know, are you showing a video of this at all? Of this? So hopefully you'll go through. I would love for you to see what we're doing now with our Bankart shift, because I really do think we are now shifting the tissue. We're not imbricating the tissue anymore. And I do think we're getting a difference, because we're about to publish our 2-year outcome from this arthroscopic inferior to superior shift, which we are at 2 years at least getting a significant improvement in the redislocation rate. Of course, we still need to wait 10 years to see the rest of it, but it is more similar to the open technique. We just don't have the superior limb to cover over the inferior limb. So, sorry, we'll get back to Jill.
Okay, so like we discussed, there's lots of different options for this, and I think someone could argue for any of these 5. So there's arthroscopic Bankart with a remplissage, open Bankart, open Latarjet, arthroscopic Latarjet, or your AAGR. So this is just a quick diagnostic scope. So it's viewing from the posterior portal. Is it going? Yeah. We can see that the previous Bankart repairs failed, and there's pretty minimal tissue remaining for labral repair. And then there's a Hill-Sachs lesion that looks fairly deep, and we can switch the view to the anterior superior portal, and you can see that the glenoid measured about 17 to 18 millimeters, and then the measurement of the Hill-Sachs is about 20 millimeters from the cuff insertion. So unsurprisingly, we did an AAGR for this case. So this is just a really brief overview of the technique, and then I have the step-by-step breakdown later on. So this is viewing from the anterior superior portal. Here we're releasing the labral tissue, which I'll talk a bit more later. And then we're going to burr down the anterior glenoid neck in an attempt to make it about 90 degrees from the articular surface. And then you can see the DTA allograft is already in place, and you can see it's nice and flush with the articular surface. And then we perform a Bankart repair over this, which again I'll talk a bit more about. Is it choppy for you guys over there? My voice?
Just a little bit, yeah.
Here you can. Sorry, can you skip one thing for a second?
Okay, hopefully that's better. So these are the post-op x-rays. And then the post-op CT scan, it's pretty routine that we've been getting 1-year CT scans to assess union and resorption. So you can see that there is some resorption with some prominence of the screws. But like we've been talking with the resorption, that rectangular block has actually resorbed into what looks like a pretty normally sized glenoid with more of a triangular shape on the anterior glenoid rim instead of that rectangle. So then we'll just go step by step for the technique. So patient positioning, we do this in the lateral decubitus position, and I rolled it back about 30 degrees. The arm is placed in a pneumatic limb positioner at about 60 degrees. The portals that we use are a little bit easier than the arthroscopic Latarjet. So we have a posterior portal, anterior superior portal, an anterior inferior portal, and then the red is the Halifax portal. So I can't take credit for the pictograms on here. I stole those, but then I added some video to it. So the first step is to open the rotator interval, which hopefully it'll play. Perfect. So we're viewing from the posterior portal. You can see we just removed the cannula from our anterior inferior portal, and then we're using our shaver just to debride that down. And our goal with this is to delineate the CA ligament, the conjoint tendon, and then also you can see the subscaps on the right and the biceps on the left. So the next step in the technique, and this is what is going to be most similar to what we're talking to with the open Bankart. So we first start by putting a traction suture at the 3 o'clock position, and then we're going to exteriorize this traction suture out of the anterior inferior portal. I think the movie is choppy too, but I'll just talk slower. It's downloaded on my computer. So this is the part that's going to be the same thing that we do for an arthroscopic Bankart repair, that I think is what gives us a little more something more similar to a open Bankart. So we make a longitudinal labral split at the 1 o'clock position, just anterior to the biceps tendon. And then you can see we follow it all the way down to the base of the coracoid. And then we're taking all that tissue from medial to lateral so that we're not missing any tissue up to the articular cartilage. And we're going down to the 6 o'clock position and until we can actually see the subscapularis muscle belly. And so all of that is going to be incorporated into our repair for both the AAGR and then for our routine Bankart repair. So next we would debride the glenoid neck, making sure again that we're about 90 degrees to the articular surface, and then we get nice bleeding bones so that we can get nice compression with our graft. And then next we measure the glenoid size, make sure we're doing the right procedure for this patient and that we're getting similar bone loss measurements to our pre-op CT. So this is just our probe from the posterior portal. Oh, the pictograms are there. Okay, and then once we're done this, we go to the back table. We take our distal tibial allograft, which is a frozen graft. And we're going to be using the anterior lateral surface for our graft. And so typically it's about 1.5 by 1 by 2 centimeters, so a rectangle. And then we attach it to this double barrel cannula, which would be the same cannula we would use for the arthroscopic Latarjet. So next. So next step is we're going to create our Halifax portal. So on the right we can see the switching stick is depressing the subscap. So we come superior to the subscap, lateral to the conjoint tendon, and then we're going to depress the subscap to the 6 o'clock position. To help with this, we will internally rotate the arm and adduct the arm, as well as debride some of the coracohumeral ligament. And so then on the outside view on the right, which is kind of paused, essentially we're just using our finger to develop that portal that's about 4 centimeters wide to make sure that we can get a nice path for our bone graft. And then we insert the graft into the shoulder through our Halifax portal. So you can see the graft coming into the shoulder on the arthroscopic view. We place it on the anterior glenoid, and our first goal is to get it as inferior as possible on the glenoid and centered around the 3 o'clock position. And then we put in 1 KR. And then after this is when we start to be able to micro adjust to get the articular surface flush, and so there's no steps. So the first step is getting it mostly inferior, and then the second steps are going to be micro adjusting so that we have the angle right. We then drill 2 cannulated screws and we insert these, and we get a lot of compression with this. Pretty much every case I've seen, you hear the compression because the screws are squeaking, which is a good sign. And so you can see that the interface between the graft and the articular surface is flush. And then finally, we make that go. Oh, sorry, my video didn't play. And then finally, we perform the Bankart repair that we've been talking about. So we have 1 anchor inferiorly, 1 at about the 3 o'clock position between the screws, and then 1 anchor, knotless anchor at the 1 o'clock position. And so you can see as we tie these, we get a really robust labral tissue that we're shifting superiorly. So that traction stitch that we put at the 3 o'clock position is going to then be inserted into the knotless anchor at the 1 o'clock position. So effectively by doing this, we're shifting the tissue from the 3 o'clock position to the 1 o'clock position. And so you can see the humerus is nicely balanced, and we have a really robust labral repair over top of the graft.
It's really a nice technique. I think, you know, in trying this in the lab without sort of your supervision, Ivan, I think the hardest part about it was getting sort of the right portal, you know, with your Halifax portal so that you could get it flush with the glenoid. And I distinctly remember, you know, some of it with the lab with the fellows, like we would get to the point where we get the graft in, but then it would be coming at like a, you know, like almost like an angle. And that was, I think, the learning curve. I think that was a little bit more challenging, I think.
And you're exactly right. In fact, every lab we do now, just like this morning, right, and last week, that's what we really focus on. Anyone who's tried this on their own, the trouble is getting inferior enough and then parallel enough. Those are really the 2 most difficult parts of this. But we can do it consistently, mainly because I've done every mistake known to man. And the trouble is the publications have not focused on that. The publications really has focused on that this is possible, what it takes to be possible, and then our outcomes, just because we're really trying to show a new technique. Now I realize that that's no longer what we need to do. We need to show people how to do it consistently. And probably the most important thing is the demonstration. So the teaching of this now we've learned quite a bit. We've taught over 70, I think our last count was 70 or 80 surgeons worldwide teaching virtually. And the teaching virtually part we realize is 2 components. One is to watch it, not watch it in this 10-minute video that, or 5-minute video that's all spliced down to show you all the steps, because all the steps are there. But you didn't see the small nuances to get us to those spots and the theory behind it to get there. So when we show someone start to finish of a case, which is about 2 hours, right? 1 hour of surgery and 1 hour of kind of the half hour of discussion before and half hour discussion afterwards to go through all the nuances and the 3D model and the holograms and why we do what we do and how we make those decisions, that helps you understand all the nuance going through it. And then to get it into your hands where we actually just take all those cameras, ship it to you, and you do it, and the only interaction I have with you is to guide you on your screen. So it's actually, I can see what you see. I see all the different angles, your hands, your back view, and then we can put any of the images up on your screen and we can draw on it. and we can guide you step by step with visual and auditory learning, that almost everyone has been able to do this on their own afterwards. In fact, at the end of every lab, they have the graft perfectly placed at the inferior 2/3 and parallel with the glenoid. So that's a success of so we only count labs successful when that happens. And it happened in everything but two labs. And those people didn't actually see the surgery beforehand. So we're realizing that the steps are actually important. If you watch first, then do a lab, everyone gets successful. The question after that is, if they're doing it in their practice, is if there's too long a lag between the lab and when they have their first case booked, some people then get hesitant again and then just want to either rewatch a lab or do another practice. But almost everyone who's skilled surgeons, can do it right away.
That's great to hear. Ivan, have you seen some of the work that Joe Aboud has published on distal radius allograft? So essentially, kind of using that and it seems promising for a couple of reasons. That the shape of it looks like pretty similar, and it's also cortical surface on one side. And so it seems like, with this graft, even though you have screws and you can like smash it down, you're still on a metaphyseal bone area. And I wonder if a graft like that, you can just, crank away because there's a cortical rim on the side that the screw heads are going through. But I don't know.
So I'll tell you, I think was it Jill? Did you go look into? I'll tell you, we've done so many of these now that our bone bank told us, you are on pause. We have no more distal tibia for you. We ran out, I forget what, because people are ordering from Halifax as well, because people realize that we have a great bone bank. So they hold stuff for me. There's 4 in the fridge, but now there's none in the fridge. They have 10 on hold. It takes 60 days after the donor is deceased and after harvest before they will release it, because they're testing for every known virus, bacteria known to man. So it takes 60 days to clear all these tests before they release it to us. So we have 10 being held, but right now we're on hold because of this. So we are looking for another graft too. I can use iliac crest. We have good results. I just don't like using it because the shaping is very tough and I can't get it aligned perfectly. Like my CTs of those distal tibias look awesome. Hopefully you saw the remodeling. I like taking the CT about a year after because all the remodeling's done. We have another paper showing when the remodeling happens, but you can't even see where the graft starts and where it ends. You have to look at the glenoid and get little hints on where we stop the resection to know where the native glenoid ends and where the new graft remodeling starts. So that's what I want. But every time you look at an iliac crest, or actually it's just iliac crest, or even or Latarjet, you can see where the growth was because it's not perfectly placed. Right, so that's what I don't like about it. So we've looked at the distal radius. I think Jill looked at the paper on this. It said it doesn't match near as much, so we didn't go down that path. I'd love to know what you think. If you think there's more to it than that. I didn't know it was Joe Aboud looking at it, but we didn't go down that path because we didn't think it was close enough.
Yeah, so I think, I think he's going to have more out there about it because he just sort of presented this at AOSSM last year. And I wrote a little commentary on it, so Orthopedics Today. And one of the dimensions that the DTA is good for, is what the sagittal kind of, the coronal plane it's good for, but the sagittal plane, you can still have like the graft may not match perfectly all the time. And I don't know, his cadaveric studies are, kind of looked pretty nice in terms of reconstructing it on both sagittal coronal views, and having the benefit of a cortical rim on one side. So I think more, I'm sure more data will come of it. People also say, and I'm sure you get this too, is you guys use frozen cadavers where you don't have the chondral surface. But I'm not sure, you guys have presented very compelling data. I'm not really sure that cartilage really matters. If I've used it here, I've always used like a fresh graft with cartilage, but maybe you don't need that.
Yeah, we've never had fresh. We can't access fresh. All ours is frozen, and we don't know how long it's been frozen for. Well, actually, we do now because we ran out of stock, so everything coming is newly frozen. 60 days.
Hey, does it matter what age these cadavers are? Like, have you ever, like, you just take them and you put them in?
So so I guess our bone bank limits it to everyone's under 60. So I didn't actually realize that, but we can tell some of these have arthritis in them, and we don't care. We just want it for the bone. It's used as a scaffold, and there's no question it's 100% remodeling because nothing is ever rectangular in the end. If I see a rectangular CT scan, it means we didn't do the CT scan at the right time. It's not remodeled yet. If it looks triangular, it's remodeled.
Yeah. You know, it's Freddie. Freddie used to always, you know, we would, you know, these companies would tell you, okay, you get, you know, whether it was for the knee or whatever, you get these like fresh live cartilage cells in there. But in reality, there's been studies here at Pitt where you look at sort of these allograft bone banks with fresh cartilage surfaces, and those cells die like very quickly. So I'm not really sure whether that is, you know, it's much more expensive here and we get them, and maybe that's America, you know. So
you can't.
One other graft I've seen described is scapular spine autograft.
Oh yeah.
I don't know if anyone's ever attempted that, but or can say anything more about it.
I've not seen that. I definitely, people have presented that for sure. You know, maybe in a place that doesn't have graft sources readily available.
So I've only been a part of 2 of them. They're very small, the amount that you can actually harvest. They don't really accomplish sort of as much of the mission that you're trying to do. Essentially, like, they're slightly smaller, if anything, than a distal clavicle one, which is already the size of a non-congruent, like a traditional size Latarjet. So you're kind of like going down to Bristow size bumps.
But also in regular Latarjet, it's not articular cartilage either. So still flat. It's better than just exposed bone. And when we go to extra articular, also bringing the Bankart tissue over top.
Great. So good discussion. I think you guys may have some cases you want to put up?
Sure. Well, we have a couple. Maybe we can just fly through like 1 or 2 of them, since it's, you know, I know we're supposed to be about to 8 o'clock here, I think, Eastern Standard Time, and 9 o'clock for you guys, I think. Do you have one? Which ones do we have? We have like the glenoid fracture, the walk anterior. Yeah. Posterior fracture. The floating. Let's do the locked anterior distal picture. This case too.
You guys able to do that? Really?
We can't see it.
We have the pinwheel of death on our computer.
Uh-oh.
No,
it's coming.
Oh, okay. You guys see it?
Got it. Case 2.
All right, perfect. All right. You know, for context for you guys over there and for you guys here, this was a case. I started practice here in 2012. This case went to my senior partner's clinic and landed in my clinic like immediately. And I was in practice for probably 2 or 3 weeks. So, you know, there's always stuff that comes up that you're like, man, like I think your fellow just said, you know, 1 year goes by quick and then you can't possibly see everything. So, all right, so we'll present this one.
Yeah, your share just went away.
Oh, the screen went away?
Yeah. You share one more time?
Yes.
And that's always the case, right? You come back, he's got all the skills, let's give him the hardest stuff right away. There you go. It's working again. Thank you.
And we present this, and I always love to call this first day in practice. So so this guy, nice guy, 56, he's a healthy guy, he's a contractor. He fell 2 months prior from a ladder. At that time, he had immediate shoulder pain, but it kind of, you know, subsided. He returned to work. And, you know, his main complaint actually wasn't pain. It was like, he just said, I can't can't really move my arm very well. And his subjective shoulder value is 20%. He's a thin guy. He's got some prominence at his shoulder. He's not been using it for some time. And by the time I see him, he's actually 4 months from his injury. And so, you know, here's affected and sort of unaffected comparisons. But basically, he's moving through his scapula. And he really has no external rotation at the side. He has very limited motion. And he's just quite stiff. And so, do you have an X-ray? Oh, no X-ray. All right. So he comes in with this.
How old was he again?
He is 56. So, I mean, I don't know if you want to call on one of your fellows there, or I can call on one of mine. Or
This
ours.
is great. We'll intervene here. Emily?
So there's definitely an anterior dislocation of the shoulder with the humeral head kind of stuck onto the glenoid.
What do you,
it honestly
Emily, what
looks
do you
like.
call?
Sorry.
What do you call that? You know, like this appearance here. There might be a kind of a name for a
it's like
dislocation.
perched.
It's a perched, or it can also be called a locked dislocation. So this looks like a. And initial thoughts that you have when you look at something like this?
Initial thought is, oh no, but but definitely lots of considerations. So first thing is it's pretty subacute now, 4 months out. There's obviously going to be a lot of humeral bone loss. You can see that on here. I imagine the glenoid, I imagine there's at least some kind of bony bankart. I don't see it on this slice, but I would expect there to be.
Okay, I think that's definitely a good thought there. You've alluded to is this has been out for 4 months, and the Hill-Sachs is sizable. How much would you estimate that Hill-Sachs defect is?
Probably approaching like 20%.
Yeah, I would agree with that. I think you look about 20 to 30%. So we're talking about some bone issues here, and maybe Ariana, what kind of soft tissue considerations would you have here?
I mean, he's been anteriorly dislocated for so long. He's pushing on his subscap, so his subscap could be stretched out and thinned. He's also going to be contracted posteriorly. He's going to have developed some soft tissue within the glenoid, or where the humeral head typically sits. So it's going to be difficult. It could be difficult to get him reduced at this time as well.
Mm-hmm.
Yeah, I think those would be my things.
I think those are, yeah.
Hi,
Please.
I'm also looking at the head and the cysts within the head. What would be the viability of that head, even if we do manage to reduce it? And what kind of cartilage are we looking at on both sides 4 months out?
I think those are very good considerations there as well. I think when you see an issue like this, most people jump straight to bone, which is important. But I think some of the things Ariana just mentioned here are important too. The front structures are going to be very stretched out. The posterior structures are going to be quite tight. They're going to be posteriorly contracted. And so this is going to be a combined bone and a soft tissue consideration issue. Do you have any other concerns that you guys have here other than sort of what was mentioned? Steve?
Any neurovascular problems on examination?
He's a good call with that too. He's neurovascularly intact, thankfully.
You want to think about the rest of this rotator cuff?
Yeah, I'm a little concerned that he didn't present with any pain. Like, I would imagine that this would be quite painful, and it makes me wonder, like, is there anything else going on in the background that may complicate his treatment or his recovery?
Yeah, I think good call. He's a little bit of a knucklehead, and somehow was able to manage past the pain phase and enter the "this is the way this shoulder is resting" phase. A nice guy though, but you know, you wonder, right? You know, what would cause somebody to live like this for 4 months before coming in? But yeah, as you guys alluded to, we were, you know, in a 56-year-old, the rotator cuff can obviously be a concern, and the MRI is a little bit hard to interpret because it's in a dislocated position, but luckily his cuff is actually intact, which I think if it weren't would also present a whole host of problems. So, you know,
can I say something too?
Yeah, absolutely.
Part of this, I think, it's a lock dislocation, and I think most of the lock dislocations I've seen, the cuff is actually intact, and that's what actually makes it even harder to deal with because it's intact. That's why it's staying out. If it was torn, you got massive cuff, they tend to be easy to reduce.
You are absolutely right. I all the ones I've seen have always had a cuff intact when it's been out that long. That's, you know, absolutely right. I think they're much easier to reduce and much more unstable when the cuff is out. So, you know, Steve, unfortunately, you're a fellow on rotation with me now. So, what's your operative plan for this?
I think you need to. Well, I guess like the major steps in my head.
I think we should send this to Halifax.
First step. Major steps in my head. The first thing is safely exposing your defect in order to actually unlock the humeral head from the glenoid. And then I think once that process is done, is the process of actually being able to obtain and maintain a reduction of the humeral joint. And the soft tissue considerations that will allow for that. And then assuming you can get by steps 1 and 2, third step would be like addressing the bone defect along the way. So
are you doing this open or arthroscopic?
I'm going to open first.
Okay.
I think I'd probably start with the anterior deltoid pectoral approach. Preparing for anatomy to be pretty different because of the anterior dislocation. Things may not be where they should be, or they may be more superficial.
Right. And speaking of which, you know, what are some considerations if you do open or don't open, but, you know, everything is distorted. So what sort of complications or risks are, you know, or what snakes are around the corner here?
Well, your axillary nerve can be pushed into the area with the humeral head dislocation, so it can be a little more anterior, might be a little more superficial than when you're dissecting. You know, depending on where the humeral head is abutting the coracoid or how anterior you are, you have your neurovascular structures in that area as well. You need to identify and make sure that you know where they are and you can address them.
Which ones?
Well, I think of your three sisters are going to be right there. They should be within the humerus, right? Like in the same region of the humerus that you would expect the standard pectoral approach.
So just remember, it's going to be very close to sort of the coracoid. Everything is sort of anterior and medial, right? So you're going to be pretty close to all your whole brachial plexus is actually going to be a lot closer than you're normally used to seeing.
Yeah. I think I would look for maybe landmarks that I know or landmarks that are safer. We typically, with deltoid pectoral approach, use the biceps to get into the rotator interval and kind of evaluate the joint from that angle. So I may look for that and see if I can use that to my advantage. And then I think the biggest question is, what do I need to do to unlock this humeral head? Once the patient's fully relaxed and we have our exposure, is it able to just be reduced, or do we need to undergo further dissection? Is that
what do you think? Do you think it's going to be easy to, even if your fingers in the rotator interval, that you can pull that out?
No, I'm expecting.
You do have strong fingers, though.
No, I'm expecting to be pretty hard to lever out.
Yeah.
So then the question is, do I need to even more further exposure, including the capsule and the subscapularis, to dissect that off to really unlock and just expose the entire humerus to free it up? I think that's where I'm thinking, at least. And then after that's done, I think, can I even reduce this once I have that all done? And in which case, what are the posterior tissues like, and is that going to be a whole nother situation to deal with, either potentially through that approach of the dislocation using enough space, or a separate approach?
So Jaron, let me and I think that's a nicely thought out plan here. So let's say you do that, you have to take your subscap off, your capsule with it, and you're able to reduce this with some effort, and God forbid not fracture the head off, which can occur, right? So you're able to reduce it, and you take your finger off of it, and it just bounces right back out. Any thoughts here?
Yeah, interesting.
So you said, okay, it's reduced, not reduced, reduced, not reduced.
Yeah, I guess you could provisionally kind of attach the capsule and subscap back on and see if that has any role in adding stability to the shoulder. I'd be worried that that's...
You're gonna reattach it with like some anchors?
I don't know.
And then your rep is gonna like high five you when you take them out and you put more in afterwards.
No.
America. I think what I'm getting at is, and you guys feel free to chime in, but in these cases that can often occur, and usually it's because of, what's that?
A posterior capsular release, like opening up a posterior capsule.
Yeah, exactly. I think that's what I was getting at. Is the posterior structures are often highly contracted, and so I think in these cases, if that's happening, don't think that this is just a bone problem and you just put a bone graft in. That whole thing is still going to pop out, even if you have an engaging Hill-Sachs lesion, because at that point it's still not a bone problem; it's a soft tissue problem. So yes, I think a posterior capsular release or a lysis of the entire capsule is sometimes needed to keep this in place. And then after you do that, you can then think about your bone grafting procedures if that's what you decide to do. I wanted to present this because a couple of weeks ago you presented a case that was kind of like this in a much older patient, and so I wanted to ask you. You did it arthroscopically, which I'm like, oh, you know what I mean? I'm like, that's crazy, but it was awesome. Would you do this arthroscopically? What would be your approach with this?
I figured that's why you put I'm like, oh my God. He's trying to show me my own case back 2 weeks later.
That's exactly why I had this on.
At least there's not 1,000 people watching this time. So what would I do? I'll tell you, I'm a better arthroscopic surgeon than an open surgeon. So I always choose arthroscopy before I open. Because I can see better. Like what you're talking about, the posterior capsule, what's tight. We had that video. I could see every structure as I go, and I can kind of take my time. And to me, I can convert to an open at any time after seeing what's inside the shoulder. So I don't know if you remember the video, but the video there kind of showed a sequence of events. We put the camera inside the back. We couldn't see anything. Actually, we saw the head. And we thought it was the inside the shoulder, but it was a whole pseudo capsule out the front. It reformed a whole new joint. It actually looked like a joint. And then I had to excise everything in the back to find the joint, and the joint looked pristine again. The glenoid looked pristine. And then you can slowly see the things that are stuck, right? You see the anterior structures are stuck to the glenoid. Then we saw that the conjoint was stuck. Then we saw that the subscap needed releasing. And then we can actually slowly reduce it. But the only thing I couldn't do was prevent the osteopenia of the head. And so my CT, when I looked at the CT and the MRI of my patient before, it didn't have the cysts. So I didn't think as much about that as I watched the head collapse as I'm reducing the shoulder. But
nauseating, right? That must have been really nauseating.
that was horrible. But what would I do? I would do it arthroscopically only because I can see each of those structures better from my hands. If you're better open, I would do it open. It's just I'm better at looking at it from the inside.
Now, Ivan, what would you do after you reduce it? Just kind of soft tissue, like typical soft tissue Bankart and a remplissage in this. Would you bone graft at the back of the Hill sacks arthroscopically? I'm just curious.
Yeah, so Hill sacks is weird. If there's no bone loss on the glenoid side, I don't have a good solution arthroscopically for bone grafting the humerus. And I think this is something that is actually the next frontier. I'm really happy with how we can bone graft the glenoid. We do not have a successful way. JK had done this. He did a great series using bone plugs in the Hill sacks, but he showed how bad it fails. And I'll tell you, that's also probably why I stopped doing the intra-articular alone grafting of the glenoid, because my first few presentations in 2014 when I was doing it, I think Rich Hawkins was in the auditorium. We were presenting in our Canadian meeting, and he destroyed me on stage to have an intra-articular allograft in the shoulder. And I'm still not recovered from that beating I had. So that's why every case I do, there's a Bankart in front. And we can. So mind you, those that didn't repair the Bankart, they actually looked fine. We did revisions of them before to take a look again because they didn't feel right. But there was no problem with it. So the Hill sacks is really the thing. Arthroscopically, I don't think there's a good way. Open, I think there is a good way to fix it.
And so I can tell you what doesn't work very well in there is like small oats, bone dowels. If you do a split of the rotator cuff and put a mega oats about 2.5-3 centimeters, that does work using like another humeral head or a femoral head, but you need something that's a bit larger structurally.
I guess a question for both of you then. Are you doing anything on the glenoid with this case? Because actually, surprisingly, this guy did not have a glenoid defect, which was actually maybe a nice thing for him. So would you do anything other than, kind of your typical arthroscopic Bankart on this, given that there's no glenoid bone loss on there?
So define no glenoid bone loss, because the CT, when you scroll down low enough, I thought there was something out there. There is enough of a periosteal change. So when you look at your CT, the axial views with it out, you saw a whole bunch of cancellous bone, or sorry, callus. Sorry, that's what I'm thinking. Sorry, see that medial aspect? When I see callus out there, it tells me that the periosteum is definitely peeled, and that's where something is going on medial. Something got pushed medial, including periosteum. So that gives it that reaction. Now, as you go down lower, keep going a little bit lower. When we got to the bottom, So see that little change, 1 or 2 frames up. One more. There. Down 1. No, down 1. I saw a little bit. So if you just go 1 more frame down, you can see there's a change. So the anterior-inferior aspect, I think, actually changed. Something has changed there. So we may not be able to perceive it, but when I see these shapes, I think there's something going on. And I'm not good at looking at it from an open view. I'll tell you, when I look from an open view, even when I get 3D models, can we show our 3D models? This is the thing. So when I do these 3D models, how do these look? Oh, we can't share our screens. We'll show those screens afterwards. They're not as accurate viewing from an open view, but viewing from arthroscopic, I find I'm much better at analyzing how much bone's lost because I can put a ruler up and I can't lie to myself how much bone there is. In something like this, with a humongous Hill sacks, even a small bit of bone loss on the glenoid, I would bone graft because that will give me primary stability. They need this little concavity, any little concavity, because this golf ball on golf tee now is a very misshapen ball, and even a little notch on that tee is no good to me, and especially the bone is very weak. So that's why I would actually augment this. I would actually try to make this a little bigger to get primary stability now, to stretch out the soft tissue, knowing that the bone is going to remodel, because that initial stability is more important than anything. The soft tissue alone won't work.
Yeah, I mean, no, I think this is great because this is like two kind of varying different approaches here. You know, I think the discussion here is just great. So I'll show you what we did. We did everything open. Basically, the approach was essentially what we talked about. Had to take down the subscap to be able to reduce it. Was able to do it. You know, fortunately, his bone wasn't, his humeral head wasn't soft. We ran into problems with the posterior capsular contractures, and so it was released basically from 12 to 6. That actually gave him soft tissue stability, we bow grafted the back of the humeral head with essentially a size matched humeral head allograft, and that did have cartilage on it. Who knows if it's viable at this point? We basically matched the surface of that using a zero form. So we basically put a zero form for the hill sacks, kind of marked it out with a pen, cut it out, and then put it essentially onto the graft. So then that gives you sort of a lemon-shaped wedge, which you cut with a saw, and you can kind of shape to fit. And we used 2 countersunk screws to do that. And on the way out, we then basically did, tease the capsule off of the subscap and then shifted that and then repaired the subscap on top. So do a humeral-based shift. And we have, this guy ended up doing quite well. I actually followed him very closely for like the first 6 weeks. I told him to come back to see me every week because I was convinced that the next X-ray would be a hill sacks with loose screws. But to your point, Ivan, we actually can get 3D bone models here at Pitt too, sterilizable, and actually for every bony instability case, whether that's mainly if it's we're doing like a Latarjet or something, I get one because I agree with you. I think it's very difficult to appreciate bone loss in an open fashion when you're there immediately, and arthroscopically, I really think you can see much better. We can estimate that much better. So it's funny, I wanted to see this guy every year and I lost him to follow-up, and then I saw him maybe like 4 years ago at, he was actually at the same hospital I operate, undergoing some kind of GI procedure. And I just, cases like this, you just distinctly remember their face. And I saw him and I said, your arm's still working? Like, what's going on? And he was still doing really, really well. So this was, but it's like a 3 week into my career case.
That's incredible. I'll tell you, that one you need to present more, because that is got to be one of the hardest things ever. You make that look incredible, because to make a wedge fit into something like that is next to impossible. There's no guide. I don't care what you did, but that's hard. I don't even know how to describe that.
I just distinctly remember feeling like, when you start practice, there's always this feeling like, like that the room is suddenly really quiet and you're like, you're the only person there and you're like, what is going on right now? And, then you do other cases.
So, we actually had this great discussion with Ben Hoyt here, talking about shaping the distal tibia and how I do this and how I try to match exactly what I'm doing. And that's based off of a reference point. There's no reference point to what you just finished doing here, because I don't know how to reproducibly cut that the way you did to make it look perfectly round.
I mean, sometimes it's better lucky than good.
It's incredible. No, amazing work. And that's amazing that you have follow-up that far, because I don't have that much follow-up on that other patient. But I think we all have these one-off cases that are crazy.
Yeah, I don't. Did you want to show some of the bone models that you guys have there?
Oh, it was just talking about. I guess we can talk about this. We'll get into this if you actually do a lab. Oh, where is it here? It's frozen. We might not work. Can you see that? No. Sorry, it might not work. We just don't have everything set up the same way we would with our broadcast. Just we're in a different facility. They won't let us have access to all this AV equipment. I'm sorry. We tried. We have our specialist here, our whole team who's really good at all this AV stuff, but it's all on lockdown. This is the Innovation Center. So let's save that for our time together.
Something worked.
Whatever you tried had worked just a bit ago.
Did it work?
Well, whatever you had tried.
Oh, sorry. What you saw was a static image. I was actually moving stuff underneath it. So it loses connection, and I'm not sure why. We can try one more time there to see. But in our broadcast, you'll see we do a bunch of stuff. We have 3D models. We use holograms. We guide you through the whole surgery and the reasons why we look at different things. Because unfortunately, most of the stuff that's published on shapes of glenoid, shapes of acromion, is really on, acromion is on cuff, right? You're talking about the acromion angle or the critical shoulder angle or stuff like that. They're all talking about cuff. They don't talk about the changes in shape from acromion for where you're going to put portals and how often they change. So if you base your portals on bony landmarks, you're going to be wrong 50% of the time, right? Like our next paper is going to come up with our medical students or our residents that way to show that our portals are actually changed 50% of the time if you base it purely on bony landmarks. And the coracoid, right? The only papers you talk about coracoid is the shape of the coracoid, size of the coracoid for when you're doing Latarjet. They don't talk about how troublesome they are in the way where the conjoint's going to be there when you're trying to get a graft perfectly parallel to the glenoid if you're not going to do an osteotomy of the glenoid or of the coracoid. So we're looking at the whole anatomy completely differently now. And I think that's going to be one of the things. I haven't told Albert this yet, but eventually I was going to try to recruit him to do another. This is going to be the next netter. We found a few people from Europe that want to do it, but we're going to find a few shoulder surgeons around the world to reimagine anatomy from an arthroscopic standpoint, because we look at anatomy completely different from how we teach medical students.
I mean, I love that. One of the things that I've always thought of, you don't, I know you don't do arthroplasty, but, sort of the shoulder arthroplasty world right now is all about pre-op planning, about sort of, software to look at bony reconstruction. But to be honest, I've thought of what you've thought of, which is to say, everyone's bony anatomy is different, which is why when you go to a certain case and you make a portal, sometimes it's really easy to get there, and sometimes it's like fucking impossible, right? You're like, what is going on? And sometimes it's because the coracoid is so lateral in certain people. I really think like the next sort of evolution in sports medicine arthroscopy is some form of pre-op planning where that you can take that into account, first, like understanding what the anatomy is, and then saying, okay, now we can pre-op plan based on sort of what anatomy we have.
You're 100% right. So I think these are our next papers that we'll work on. I think it'd be a great joint venture too. And what we realize, what we realize is that not everyone's going to have a 3D model. I know I do. I know you do down in Pitt, but most people don't. What we need to do now is convert those 3D models and figure out what the perfect X-ray is going to be to be able, oh, whoa, look, this works. So Charles has gratefully put this on. So these are random models that we have. I think they're just 3 different shoulder models from maybe 3 different cases we just did. I can't hold, can you hold this here? So only reason why I'm showing you this is because these are just 3 shoulders. Are they all right? Oh, good. They're all the same size. You can see this patient we just did last week with posterior bone loss. And if you were just to look at this on face, you're like, there's no posterior bone loss. But if you look at it from this view, hopefully you can see the bone in the back, where my hand is completely off plane. So this is not even there. So if we saw intraoperative surgery, you would not see this at all. And that is the amount of bone loss you have going on here. But that's not what we're talking about. Let's talk about the shape of the acromions, because everyone talks about the posterior portal as the posterior lateral corner. So if we look at the top, this person now has an os. But which part is the corner? Is it here? Is it here? It's round. I don't know where to put the corner, right? Because we want to compare that to if, oh shoot, can I borrow your pen? So So we always talk about what the perfect posterior portal is. And to me, right, we only teach this arthroscopically to say the perfect posterior portal is 2 centimeters inferior and medial to the posterolateral corner. But I really think the posterior portal should be something that allows you to get perfectly parallel to the face of glenoid so you can reach the front of the shoulder and kind of right at the level of where the bone loss would be if you're doing bone loss surgery. So if you're doing Bankart or bony surgery, that's where it should be from an anterior portion. For a posterior portion, I want posterior portal to be perpendicular to that bone loss. So it's going to be a very different location, right? So hopefully you see where the difference is. And in this patient, you can see the acromion is nowhere in the way. But the only problem is we can't see where it is to the posterior lateral corner because that's way more medial than I thought it would be. Whereas you compare it to this patient, we'll do the same thing. So there it is again. This is 2 random patients. I would say that's probably where I want it. So much closer to the acromion on the, what's this, the sagittal view. And if I go to the superior view, we're now, well, it depends if you use this as your posterolateral corner or this is your posterior corner. We're right at the posterior corner, not medial. And then again, I haven't tested these yet. This is the third one. This doesn't have bone loss. But if I wanted my position here, I can't actually get high enough on this one to get halfway there. So I'm going to really touch the acromion. And then looking from the top, look how much medial I am compared to the posterolateral corner here, right? So the 3 different cases, really big. And similarly, if you're looking here, the conjoint, so if I put this on face, where's the coracoid? So this one, the coracoid is not really in the way. So if I try to get this parallel, this one looks like it's going to be pretty easy. If I come over here on this patient, you can see how much more difficult this is. This is, you know, probably a chopstick width more lateral. we'll go, this is a Asian food processing. And then this one, look at this. This is probably 3 chopstick widths, right? So, so just the variation on 3 cases. We can take that off. These are just 3 that my fellows brought up. It is so variable. So if we just teach people how to do a posterior portal with your bony landmarks, oh, I can't tell where the camera is. It's not going to work.
Yeah, I love it. I mean, if that was an unsolicited invitation, the answer is yes. I would love to collaborate with you on that.
Awesome. Okay, so it'd be a great thing in future to work together. Anyway, I think it's past time. Really appreciate working together. This was a fantastic combined journal club. I would encourage maybe we can do this in annual time because it's great for our fellows to kind of hear from your fellows as well. And I think we're gonna get better at doing this each time.
I love it. Thanks for having us. Like, this was really fun. Yeah, really great.
Thank you.
Have a great night.
Thank you.